Good afternoon, dear colleagues. My name is Sara, and my research focus is about leadless pacemaker, practical application, and patient selection in everyday practice. I would like to special thanks to my supervisor because of his time and great support all throughout the project, and also very great thanks to Dr. Ghare as a cardiology group leader that he's supporting us all through the project, and for sure a special thanks to Dr. Ghare because of his wise leadership, because he's trying his best to make us to create the best possible results and projects in the world. And also the whole translational team. My vision is introducing innovative approaches in medicine through translational research from bedside to bench and bench to bedsides for my patients all over the world. And the mission is collaborating with Semmelweis University, a cardiovascular medicine, as a national leader in health for the purpose of improving the health and well-being of Hungarians and beyond. My research focus is as following: intracardiac leadless pacemaker, long-term safety over traditional pacemaker. It's a systemic review and meta-analysis. And the second project is an international survey study, which it is to understand the real-life patient selection and indication of leadless pacemaker. As a background, the leadless pacemaker is less invasive with fewer complications. The primary advantage of the leadless pacemaker is that it eliminates the several complications associated with conventional pacemaker, including pocket infection, hematoma, and lead dislodgements and fracture. 90% is smaller than the conventional, and it has the cosmetic appeal, and it has a self-contained generator and electrode systems implanted directly into the right ventricle. And the future of the leadless pacemaker technology is promising. Usually one of the beneficial applications for leadless device is in high mortality, high risk patients, including the post-TAVI patient. The future perspective of leadless pacemaker is as this diagram. About the first projects, which it is long-term safety of the leadless pacemaker over the traditional pacemaker. I already wrote the manuscript, and our target journal is as following. The background would be the pacemaker-related infection is one of the most costly complications and has a very high mortality rate, 30 to 35%. Cardiac tamponade during and after leadless pacemaker implantation is a high-risk complication, and pacemaker dislodgement in pacemaker-dependent patients may lead to a fatal outcome. Leadless pacemakers were designed to reduce lead-related complications, and articles suggest that they are associated with reduced infection rate and dislodgement, but a higher tamponade rate. That's why the systematic review is needed. The clinical question is that is leadless pacemaker use associated with different rate of mortality, complication, and revision compared to conventional pacemaker? And my PICO framework as following, and the hypothesis is that leadless pacemaker has less complication than conventional pacemaker for right ventricular pacing. I used the following database in November 2nd, and the key search was as follows. And out of 6,450 articles, we used 22 articles for qualitative systematic study, and 12 articles was included in meta-analysis, which it is quantitative. For 1 month's complications, as you see in our forest plot, we have 42% less complication in favor of leadless pacemaker, However, it shows that it's not statistically significant, but it's clinically relevant. The second outcome is 6 months complication rate, and the result is 50% less complications in favor of leadless pacemaker. However, it's not statistically significant, but clinically relevant. And for 12 to 24 months of complications, we have 71% less complication in favor of leadless pacemaker. It's statistically significant and clinically relevant. For 1 month infection rate, we have 71% less infection rate in favor of leadless pacemaker, and it's both statistically and clinically significant. For 6 months infection, we have 62% less infection rate in favor of leadless, and it's both clinically relevant and statistically significant. And for 12 to 24 months of infections, we have 76% less infection in favor of leadless pacemaker. And it's clinically relevant and statistically significant. As a summary, for some of these outcomes, we managed to pull lots of patients, and they are all from direct comparison studies. And for limitations, they are all observational studies, and some of them implied historical cohort, and the strength of evidence is not that high. And for our conclusion, in the first months, there is no difference for overall complication between leadless and traditional pacemaker. However, this observation is dominated by one study. In midterm follow-up, 12 to 24 months, the leadless pacemaker seems to have less complication compared to traditional pacemaker. And the leadless pacemaker shows a lower rate of infections in all comparisons, 1 month, 6 months, and 12 to 24 months. And as a summary, patient with high risk for pacemaker-related complication and infection should receive leadless pacemaker because leadless pacemaker has lower complication rate in the midterm follow-up and lower rate of infection compared to traditional pacemaker. And the implication for research is more studies are needed, if possible, in the form of randomized controlled trial. The second study is an international survey study. Leadless pacemaker reduced major complication by 63% compared to traditional pacemaker. The FDA approved the leadless pacemaker at January 2020. We are using the leadless pacemaker in home bed hospital from 2014. And for sure, in 4 more hospitals, we use leadless technology. Per survey in Europe 2018, high cost of the device, 91%, was the main reason not to implant the device. And 72% of this survey anticipated that the increase in utilizations would be in the next 2 years. That's why this is a reason for reassessing. Clinical questions is that which patient population served better by leadless pacemaker versus conventional pacemaker? And what are the major barriers that patients do not receive leadless pacemaker? The aim is that evaluate real-life patient selections for leadless pacemaker implantation and identifying the major cause which prevent the widespread use of the leadless pacemaker technology. And the hypothesis is high price, awareness, insurance company coverage, training and knowledge of the cardiologist, all are the major barriers of leadless pacemaker implantation. Technical points is that we already made our questionnaire and we are planning to send it for arrhythmia societies and get their feedbacks. And this is a summary, and thank you very much for your kind attention. My quote would be, only from heart can we touch the sky. And the translations would be that if we make our heart the center of our actions, we can tap on the limitless potentials of ourselves for sure in favor of our patient and all living beings all over the world. Thank you very much for your kind attention.
Thank you for your presentation. I wanted to ask you concerning your second project, that you mentioned that you would like to investigate that in which population would it be beneficial to have the leadless implantation, and what is your hypothesis? Is there a special group of patients where you would really advise the leadless technology?
Thank you very much for your question. Actually, the target is that in the same populations that they may be eligible for the right ventricular pacing, why the doctors doesn't use or do use or prefer not to use leadless versus traditional pacemaker. So this is our target. The patient group is obvious because the people who need right ventricular pacing are the one who, and the people with atrial fibrillations, AV node blockage, and certain criteria that the industry also suggests, and also doctors know about that. But why the selection criteria goes toward the traditional, that's a main focus. So we are planning to understand why they don't choose leadless if it is available and free of charge for them.
Okay, so if I understood correctly, it's quite clear that which is the patient group what you would like to include.
Almost.
And it's more of a technical problem.
Yes, yeah. It's almost clear because that's the framework of the usage of the leadless.
Okay, thank you.
Thank you.
Okay, thank you. Just want to ask, what are the known complications of the leadless pacemakers?
That's a good question. Thank you very much. So far, based on the articles, there is a benefit of the leadless, which it is eliminating the leadless pacemaker infections, and also in mid-term complication. But what are the main complications that we found based on our research in the articles was tamponade, but that's also few cases. But tamponade also can happen in other situations too. But otherwise, other criteria, other outcomes, it's in the favor of leadless.
There is one question from me. How did these authors define the real patient with a high risk of complication rate with the conventional transvenous lead pacemakers? How did they define the high-risk patient?
Oh, how do they define the high-risk patients? So the definition of high-risk patient, is that the question?
So how do you select all those patients who are eligible much more for transcatheter leadless pacemaker implantation?
So the high-risk patient, based on what I understood from your questions, the high-risk patients for transcatheter.
Who are those patients who are at high risk for complication rates with the normal traditional pacemaker implantation?
So far, the articles that they were focusing for leadless implantations, they were 80 plus years old with valvular complications, TAVI, post-TAVI, and which they had also other comorbidities like diabetes, hypertension, and other underlying diseases. So those people, especially with the high age, which had other underlying disease, was defined as a high risk, and the main implantations were in those patients in those studies, in all of the studies so far. I think the next step would be they will distribute it more confidently among the young and other group of populations for watching in the long-term effects for those populations as well.